our group, but for hand surgery and microsurgery in Brazil. So thank you for your time. Everyone expects your visit again to Brazil as soon as possible. Yes, that's true. You will have been with us many times.
Yes.
But now you have 30 minutes to talk about the current protocol adopted by Mayo for the treatment of traumatic plexus injury in adults. And after that, we will discuss some cases with you. Okay, so thank you so much.
Okay, I'm going to share my screen. I have two screens, and sometimes that causes an issue. So let's see what happens.
Okay, you can share your presentation.
That worked well. Let's see. Can you see that?
Yes, perfect.
Good.
Yes.
Well, Dr. Matar asked me to speak about Mayo's approach to brachial plexus injuries. It's a complicated subject, but I'll do my best in 30 minutes. Brachial plexus injuries occur, at least in the US and Canada, about 1.2% of all trauma cases. Most are young men, previously healthy, most involved in high energy trauma, and most commonly have a completely flail upper limb, often associated with chest wall and vascular injuries and fractures. The nerve injury itself is a complex problem with a large diversity of opinions regarding what can be accomplished and how best to do it. Many variables have to be taken into account, and a multidisciplinary approach is usually necessary. We have a team of folks who do this, physical medicine specialists, pediatric orthopedists, Bassam, who's a shoulder elbow, and then Alex Shin and I, who do the microsurgery, and Rob Spinner, a ortho and neurosurgery trained specialist. Most injuries are supraclavicular, most are severe. Infraclavicular injuries involving the terminal portions of the plexus are less common, generally less severe. This old study from Narakas, in his experience, 71% upper extremity, supraclavicular. Ours are probably more like 90%. Most of the injuries involve the roots or spinal nerves, and we talk about postganglionic and preganglionic injuries. Postganglionic being injuries outside of the spinal canal that may be either stretched or ruptured. Preganglionic injuries being avulsions of the nerve root from the spinal cord. But of course, also there's extensive longitudinal injury to the plexus that's almost always there and results in large nerve gaps. 90% of our cases have all 5 nerve roots avulsed. So it's different from Bertelli's experience, for example, since he tells us everyone has a C5 nerve root. Every patient, of course, wants normal function, and part of our approach is giving the patients a reality check, what can be achieved. And I think, like everyone else in the world, we prioritize our treatment, highest priority being elbow flexion, second highest a stable shoulder, and if possible, restoring external rotation. And grasp is a lower priority because of the complex nature of grasp, as you see here, and the difficulty in achieving it. And an intrinsic function is almost never achieved. So these priorities reflect what we can accomplish and what is useful to patients. In point of fact, in adults, function below the elbow can't be obtained routinely by nerve grafting or transfer. Some exceptions, such as the work that Wang is doing in Beijing at Jishuatan Hospital with C7 crossing behind the esophagus and shortening the humerus, may be something acceptable in China, but probably not in our country. Elbow flexion is generally readily achieved, and shoulder function is often disappointing. Prehension does require special techniques. The two strategies used to obtain grasp have been contralateral C7 nerve transfers and functioning free muscle transfers, either single or double. Factors in planning treatment include, of course, whether the injury is complete or incomplete. Is it a pre or post ganglionic injury? And what about time, elapsed time from injury, patient's age, and distance to the target muscle is another time factor. Limited expectations result because of muscle changes with denervation that cause atrophy and loss of acetylcholine receptors, and the slow rate of nerve regeneration, roughly 1 millimeter a day, resulting in a long time to reach targets that move the hand. Axons do regenerate at a rate of about 1 millimeter or so a day in man. Forearm muscles are not reinnervated typically for 1 to 2 years. And again, with muscle atrophy, these acetylcholine receptors also tend to diminish ultimately and make the muscle unresponsive to a stimulus. So timing of reconstruction, an emergency or at the time of injury, typically we don't see these injuries. Sharp injuries with an open vascular injury can be assessed and treated emergently. We've only done a handful of those. Most of ours are closed traction injuries, and we operate early if they happen to come and see us before 3 months, if they have the signs of root avulsion and a physical exam that supports that. More commonly, we're operating in a range of 3 to 6 months post-injury. You need to wait at least 3 months in a suspected rupture to be sure that the nerve injury is less severe and may recover spontaneously, but waiting more than 6 months results in diminished results. And beyond 6 to 12 months, the results are going down. After 12 months, nerve surgery is not really a possibility. We're looking more at salvage procedures and free muscle transfers with extraplexal nerve transfers. So initially, if you think of all the things you can do with a nerve, you can free it from scar, you can repair it if it's a sharp injury, you can graft a nerve, and you can do a nerve transfer either from an intraplexal nerve or from an extraplexal donor. And functioning free muscles are an adjunct that we use frequently. Subsequent recovery may allow some additional procedures such as joint fusions, shoulder or wrist, commonly base of the thumb for pinching, tendon transfers if any muscles have recovered or were spared. Tenodesis procedures such as anti-claw procedures may be indicated. Neurolysis is something that we do very seldom. We do it if there's a nerve action potential across the zone of injury and if there's any evidence of a recovering muscle on exam on a preoperative electrophysiologic study. Nerve grafting is by far the most common approach to reconnecting nerves, and it's only effective in adults, again, for muscles at the elbow and above for the most part. It does not generally successfully restore shoulder external rotation in global injuries, but works pretty well for restoring infraspinatus function in upper trunk injuries. A nerve transfer is a transfer of a functioning nerve to a new distal connection. They're usually done when the lesion cannot be repaired or when the result may be superior to a graft. An example of that would be this Dr. Hara's Japanese procedure of transferring intercostal motor nerves directly to the biceps, which places the point of recovery much closer to the motor end plate of the biceps than a nerve graft, and also is available when the C5 or C6 nerve roots are not usable. Intraplexal nerve transfers are used primarily for upper trunk or C5, 6, 7 injuries. Distal nerve transfers may be indicated rarely in the very rare Klumpke or C8T1 pattern of injury. The most useful transfers are the Oberlin or double fascicular transfers for elbow flexion, and the radial to axillary transfer, a triceps motor branch to anterior division axillary nerve for shoulder for deltoid function. Extraplexal sources are typically spinal accessory nerve and intercostal nerves in our practice. We've used the phrenic nerve, including using thoracoscopic harvest from inside the chest to lengthen the nerve. We've done 80 or so contralateral C7s. We've abandoned those two nerves as extraplexal sources due to poor results. And in a delayed presentation, certainly a functioning free muscle removes the issue of elapsed time that affects denervated skeletal muscle in a lower motor neuron injury. We also use it for grasp because the gracilis muscle is long enough to reach into the forearm to power hand function with a proximal reinnervation. The approach that we take, therefore, especially for global injuries, is to try to obtain a stable shoulder and elbow flexion, and using intercostal nerves for shoulder fusion. We only use this without restoration of grasp if the patient clearly states they don't want grasp, and if they have a vascular injury that precludes the use of a functioning free muscle. Some of our patients have very stiff hands from basically a nerve effect that produces swelling and stiffness. This type of limited goal surgery, therefore, it is something that we do use as needed at times, but for the most part, we're trying to obtain grasp as well as shoulder and elbow function. Elbow function is the highest priority, and this method reported by Tsuyama and Hara remains a popular and useful method. We did this today, as a matter of fact. Motion with gravity eliminated typically occurs with over a period of about 1.5 years, but it takes a year or more to get elbow flexion against gravity. The results have been somewhat variable, and probably 70% or so of patients around the world successfully get at least grade 3 elbow flexion. So it's a little disappointing. For example, this study by Kawai and Kawabata of 635 intercostal nerve transfers had only 35% grade 4, 31% grade 3. So that's 66%. Any function below that level is clearly not acceptable. And Merrill's study of 965 nerve transfers was very similar, about 70% M3 or greater function. And so that's a bit disappointing. Shoulder function in global palsies, the major goal that we have is obtaining some external rotation so that the elbow will, or the hand will move in front of the body and not move along the front of the body in a rather useless position. Other studies have emphasized abduction commonly or internal rotation strength as documenting a good result. We find these motions relatively useless for a globally injured patient. Again, external rotation positions the arm in front of the body and permits that hand to mouth positioning. Options are limited in a global palsy. If they do have a C5 nerve root, a graft is indicated. Spinal accessory is often used to the suprascapular nerve and glenohumeral fusion. So this is kind of the classic approach. The spinal accessory nerve is a pure motor nerve. It's easily found on the deep surface of the trapezius. You save the most proximal motor branch and transfer it directly to the suprascapular nerve for priority number 2, shoulder external rotation. C5 nerve grafting can also be used. And in a global palsy, these results, either by graft or by nerve transfer, have been disappointing. Results are much better in upper trunk injuries. This study by Doi demonstrated forward flexion of 70 degrees, abduction of 77 degrees, external rotation of 16 degrees. And he felt that the serratus anterior, if functioning, provided overall better function. Of course, that moves the scapula and results in scapulothoracic positioning. Alternatively, tendon transfers for shoulder function can be considered. The trapezius transfer, the Saha operation, has been the one that everybody has used for decades, but it doesn't actually work very well in a completely paralyzed shoulder. The problem is that multiple muscles are affected, and if only the deltoid is reconstructed with a trapezius transfer, it tends to pull the humeral head proximally and causes it to impinge against the acromion without producing useful abduction. Dr. El Hassan has pointed out to me that there are many muscles moving the shoulder, and the prime movers are the deltoid and the pec major. The steering group are the rotator cuff muscles, and the depressor group are very important to hold the humeral head and prevent it from migrating proximally. In a C5 and 6 palsy, all three groups are affected. Although the subscap and teres major retain function through C7, and the pec major usually, of course, has medial pectoral nerve working. The result is an internally rotated and adducted posture. So in order to treat these, Bassem El Hassan, one of my colleagues, has studied how best to accomplish improved motion, including external rotation. In a study he published in the Journal of Bone and Joint Surgery a few years ago, there were quite a distribution of patients in terms of pattern of injury. We found that the lower trapezius transfer to the infraspinatus was most effective, although at the time he was often doing multiple additional tendon transfers to try to substitute for all of these important muscles. This is the lower trapezius transfer, and it can be brought over to the infraspinatus by tunneling and sutured in there for external rotation. The results were promising in his study with a mean of 20 degrees of external rotation. And if the spinal accessory nerve does not have to be used for some other purpose, thereby paralyzing the lower trapezius, this is a very good way of restoring some positioning. Grasp remains the difficult problem. Again, the problem is both the time it takes to reinnervate motors if nerve grafting is attempted, and the complex function that is required. The contralateral C7, again, GU uses the entire normal C7 nerve root. Panupan Songcharoen from Bangkok uses only the superior half of the C7 nerve root. It can be reconnected usually with a vascularized ulnar nerve graft to a variety of distal targets. Here you see a vascularized ulnar nerve graft from the paralyzed side being passed or tunneled and will be passed around to the normal opposite C7 nerve root. This is the hemicontralateral approach that we used in our studies. And this study by GU was, by far the best at the time, reporting 60% up to M3 recovery, outcomes affected by delay, by age, and whether or not a vascularized graft was used. Panupan study found only 28% with M3 recovery. In a report that we published in Journal of Hand Surgery, we had 61 hemicontralateral C7s using Panupan's technique. 23 of those were vascularized ulnar nerve grafts to the median nerve for hand function. 24% of those had some EMG evidence of median nerve motor reinnervation at an average of more than 2 years post-op. 35% had some transient motor deficits, and one of our patients had severe permanent hand and grasp weakness that required tendon transfers on the normal side, kind of a nightmare. But I don't know if this is going to play or not. Let's see. Nope, sorry. We found our results, although there was some EMG evidence of recovery, only 6% of patients had any sort of grasp function at all, and none of it was useful at 40 months of average follow-up. We have not used the contralateral C7 for a decade or more. And so we just don't use it. Subsequently, there have been some improvements, but we've switched to functioning free muscles, something I had done before contralateral C7. It does require adequate skin cover and a bed for tendon gliding. You need to have an available motor nerve. You need to have normal vasculature. And typically we will not do a free muscle in someone who's had an injury to the axillary or subclavian vessels. And importantly, they need to have supple joints. Many of our patients have a very stiff dystrophic hand, and those people simply don't do well. Even if you attempt to get capsulotomies and lots of therapy, they never seem to really get a very supple hand and don't do well. The spinal accessory or the intercostal nerves are what we use typically to power a free gracilis flap. Rarely we'll do a fascicular transfer. If, for example, the biceps were destroyed, but the ulnar nerve was functioning well, then you can do an Oberlin type procedure to a free muscle flap. You can use a regenerated local nerve after a previous nerve graft or transfer. That would be a rare event for us. We get a magnetic resonance arteriogram on all of our patients beforehand, looking specifically for a patent axillary artery. And we typically will use the thoracoacromial trunk artery and the cephalic vein for arterial inflow and venous outflow. We typically are now using a one free muscle, one stage approach. I used Doy's double free muscle flap when I was operating alone with 2 separate procedures. Everything has to work perfectly. It's rather stressful for the physician and the patient to go through 2 big operations separated by just a few weeks. And now we have a multiple surgical team approach that allows us to do this operation in one surgical day. We usually have 2 teams. Alex Shin usually harvests the muscle flap, and I get the intercostal nerves or the spinal accessory nerve and the vessels ready. The free muscles, again, do allow rapid reinnervation with a direct nerve transfer to the gracilis obturator nerve branch with some reinnervation, typically beginning by 4 to 6 months post-surgery. And it also removes the issue of the time a muscle is denervated. Finally, it's a long muscle that can reach the forearm because of its size. So we use the obturator nerve and the major vascular pedicle vessels. Doy had the Lambeau procedure, Lambeau meaning flap, of course, in French, but with trouble pronouncing L, he called it a Rambo procedure, and that seemed to describe Dr. Doy very well. I spent some time with him there. You could see me as a younger person in Ogori, Japan. He has some lofty goals: independent finger flexion and extension, independent elbow flexion and extension, and protective sensation in patients with 4 or 5 nerve roots avulsed. And typically, it does require initiating surgery within 6 months of injury. It performed in 2 stages, the first being an exploration of the plexus and the C5 nerve root, using it for shoulder if you can, doing a free gracilis transfer with spinal accessory nerve for combined elbow flexion and finger extension, done in the fashion you see here, using the brachioradialis and radial wrist extensors as a pulley for the passage of the muscle across the antecubital fossa of the elbow. Although we found that we typically need to create a reinforcement using flexor carpi radialis, as you see here, a technique David Koo described from Singapore to stop it from bowstringing. And then you go ahead just 6 or 8 weeks later with a second free muscle flap, uses another gracilis muscle, ipsilateral gracilis, that is neurotized with 2 intercostal nerves. The triceps is reinnervated with 2 additional intercostal motor nerves. And then the sensory component of these 4 intercostal nerves goes to the lateral cord contribution of median nerve for some hand sensibility. I'm hoping this is going to play here. Oh, for goodness sake, I'm sorry. This is a double free muscle flap case of mine from years ago. He had a very good result. He had a C5 nerve present that we used to neurotize shoulder, and he got external rotation back. He had full elbow flexion, some useful extension, and some useful grasp. But if you ask him, does he find it useful? His answer is no, I don't use it. And that's the problem with grasp procedures in general with brachial plexus injuries. We've subsequently switched to this single muscle option. It restores grasp but not release in one operation. It involves using the spinal accessory nerve with an interposed nerve graft to a triceps motor branch, 2 intercostal nerves, motor nerves to the biceps, 2 to the gracilis, and then the same sensory transfer that I described in the previous slide. Because we're not getting wrist or finger extension, we have to fuse the wrist later on, and typically we'll fuse the thumb CMC and IP joint to position it for key pinch, as the single muscle will both flex the thumb and the fingers. This is an example, a 21-year-old college kid who had a snowboarding mishap, flail extremity, severe burning pain that was unrelieved with gabapentin, a Horner's syndrome, no motor function other than trapezius. And this was his chart of muscle exam. You see the only thing he has working is some serratus and rhomboids, as well as a lower trapezius. And his EMG demonstrated basically no activation, although the C5 paraspinal muscles appeared normal. He had no visible dorsal rootlets at C5 and a slightly enlarged nerve root. We were not certain if C5 was usable on the myelogram. C6 appeared likely to be avulsed with deviation of the cord, and there was a small meningocele in the foramen of C7. C8 had an obvious meningocele with a root avulsion, as did T1. He had normal diaphragm function, and his MR arteriogram was normal. So the surgical plan in this guy was to inspect and determine the usability of C5 and C6. We use intraoperative somatosensory and motor evoked potentials to do that. The plan was to go ahead with a grasp procedure. We gave him the option of not doing grasp, but that's not what he wanted. And so we did our 1-stage reconstruction, contralateral C7. I'm sorry, that's not what we did. This is what we did. We explored C5 and C6 and explored the plexus. He had a rupture at Erb's point, with a good signal from both C5 and C6 nerve roots. So we did a one-stage reconstruction. Gracilis was transferred for finger and thumb flexion, biceps with intercostal nerves 5 and 6. C6 was used for triceps with a sural nerve graft, and C5 to both axillary and suprascapular nerves with sensory intercostals for hand sensation. And he had a wrist fusion 6 months later. He began to get some active finger flexion at 6 months. And at 15 months, he had 20 degrees of shoulder abduction and 15 of external rotation, and an elbow range of motion from 30 to 100 degrees of flexion with grade 4 strength. And I bet this isn't going to play either. He made a videotape of him playing his guitar. He had a little splint that he made that he could hold a guitar pick in his right hand, and he played us a little song to show his result. I think the future, though, may lie in the development of orthotic or prosthetic hands that function with direct input from either muscle or spinal nerve stimulus. And Alex Shin is doing some work with our local prosthetists in fitting some of our patients with prostheses. They need to have sufficient strength of elbow flexion to support a forearm-based implant, or they need to have an above elbow amputation and prosthetic fitting. The biggest problem here, of course, is control, but progress is being made, and this may be honestly the wave of the future. Ramesh, I think I'll stop at that point. I've used a little more than my 30 minutes.
That's okay, Alan. Thank you so much. We can discuss some cases now just to have your opinion and something that you want to discuss. So I will share my screen now, and I will try to show one patient for you. Are you seeing?
Yes.
Can you hear me? Okay.
Yes.
So let me see. That's the case. It's a 38-year-old male, motorcycle accident 4 months ago. So a traumatic injury of the right brachial plexus, no shoulder, no elbow flexors, some weakness, paresis of the triceps and wrist extensors. Hands okay, so flexion of the wrist and fingers working well. No supraclavicular tinal sign, sensory evaluation 5, 6, and 7, anesthesia, MRI showing preganglionic or vulsion injury of C5, 6, and 7. So the surgical procedure was neurotization of the spinal accessory nerve to the suprascapular nerve, the motor branch of the radial nerve for triceps to axillary nerve, anterior branch of the axillary nerve, and a double neurotization for musculocutaneous using a motor branch of the ulnar and median nerve. So that's the images, the transfer for the musculocutaneous using ulnar and median nerve, the spinal accessory to suprascapular, and a motor branch of the radial nerve to triceps to axillary nerve. That's the result after 10 months. And we can see here at 18 months, it's a good elbow flexion, very nice. Some external rotation. He improved a little bit external rotation in 18 months post-op, and also the shoulder abduction. So that's the final result. The patient is happy with the result, but we have some questions for you. Your opinion about if you see an advantage in double reinnervation of elbow flexors using ulnar and median nerve. What's your opinion? And when there is paresis of the triceps, weakness of the triceps, if you still using motor branches to reinnervate the axillary nerve, the anterior branch, and what's the limit of the weakness of the triceps that you secure to use that motor branch? Or any other tips about the triple nerve transfer technique for upper trunk injuries? So please,
Sure.
your
Well,
considerations.
you may know we had a study about the single versus double fascicular transfers. In our hands, there wasn't any statistically significant difference between the two. I think when you have a C5, 6, 7 injury, there are fewer nerve fibers reaching the hand, and I do think it's a little bit riskier to take portions of the median nerve for brachialis reinnervation. We don't do it any longer. We typically are just doing an Oberlin, but we've done double fascicular transfers and still do on occasion, probably more likely in a pure C5, 6.
Okay.
And clearly we would use the same approach that you use, Ramas. Regarding triceps motor strength, I think that's a tough question for anyone to answer. I can't give you a scientific answer. I can tell you that what we grade M4 is if you can break the triceps like you normally cannot in a normal triceps grade 5, the amount of strength that it has is probably best determined with some kind of torque measurement rather than the BMRC grading. We did do a study of elbow flexion strength, which maybe you read, that we found that M4 strength of biceps typically amounted to about 15% of normal contralateral strength, 15%. And so the BMRC grading system is heavily skewed towards the weak end of muscle performance. And so I think while I probably would proceed with a transfer to the axillary nerve, in most cases, maybe we ought to be thinking about doing some torque testing and comparing its strength quantitatively with the opposite side, and then we could probably answer the question. So maybe that's a task you guys can accomplish in Sao Paulo.
Do you trust in electrical study, intraoperative electrical study to choose the motor branch, or to trust in the motor branch to transfer to the other nerve?
Well, we do use a handheld stimulator typically to identify branches and to evaluate the strength of the contraction. So yes, we do that, but we don't do anything quantitative with electrophysiology.
Okay. We have other cases. Alvaro, you can share your screen to show the next case, please.
Can you see my screen?
Yes, I do.
Yes.
Okay, perfect. So this is a case of a young female, 34 years old. She presented to me 6 months after a Shivanoma resection at the right axilla. Actually was performed by a gynecologist who thought it was a lymph node. So he expected it anyway, even if he realized it was not a lymph node, he decided to resect it. As she presented to me with 0 intrinsics, no FDP, FDS, FPL, some weakness as the FCR, FCU, pronatal teres, and quite good function of extensors of the wrists and fingers. So I made a plan to perform a distal nerve transfer, the radial motor branch to the anterior interosseous nerve. This is the skin incision. So this is stimulating the motor branches of the radial nerve, intraoperative. And during this exploration, the whole median nerve and the anterior interosseous nerve didn't show any kind of contraction, so we confirmed that there was an injury. So we stimulating the median nerve and the anterior interosseous nerve branch, no function. So in this case, actually she had a bifurcated anterior interosseous nerve. So I decided to neurotize both branches of anterior interosseous nerve with the radial branch. So this is the function 6 months post-op. At the left, it was pre-op just to compare. So it's a quite a fast response of reinnervation. And then we proceed with some tendon transfers for intrinsics, the house transfer, and also the Burkhalter, the EIP to APB transfer, classic one, for opponent. So the left, the initial function, and the right, the final post-op function after the 2 tendon transfers and the nerve transfer. The house intrinsic reconstruction was not very good for the second, third finger, worked better to the fourth and fifth finger, but the patient was very satisfied. She could drive and do a lot of tests she could not do before the nerve and tendons transfers. So Dr. Bishops, some questions for you is, what is your opinion about distal nerve transfers for finger and thumb flexion? It's not a very usual scenario, but it does happen. Targeted the anterior interosseous nerve. What do you think about other options for nerve or tendon transfer in this particular case? Would you think about other options? And what do you think about this hybrid approach, combining nerve and tendon transfer for distal nerve injuries?
Oh, thanks, Alvaro. Congratulations. What a beautiful case. What a wonderful result. Yeah, the two first questions are basically go together. I mean, it's the old argument. Do you do a nerve transfer, or do you simply do a tendon transfer? And I've typically been asked to defend the tendon transfer option at meetings, and I must say that we've tended to mostly do that. And the results are, I think, a little bit more predictable. What you've shown is an outstanding result. I doubt that all of your results are quite as outstanding, although maybe they are. But a tendon transfer has a fairly predictable outcome. Susan McKinnon always shows someone who can move fingers independently. And if you can get a result like that, it's clearly superior to a tendon transfer. So my experience with distal nerve transfers is actually fairly limited, and I'm still in the tendon transfer group of thinkers. Even Susan, I think, is fairly pragmatic or practical about what she does and what the patient's wishes are. If they're looking for a recovery in 2 months, then you would do tendon transfers. If they're willing to wait a year to see their final result, then you do the other. And she would often, in a injury, often combine a tendon transfer. For example, in a radial nerve situation, do it. Internal splint type transfer for wrist extension and a distal nerve transfer for fingers. So I think that's very reasonable as well. Alvaro, did you give any thought about exploring the area of injury? It looks to me like it wasn't purely median nerve, because I think you showed the flexor carpi ulnaris was weak. She clearly has intrinsic paralysis, so this must be a medial cord injury, I think. Did you give any thought to approaching it at the zone of injury?
Yes, that's a good idea. Actually, I was very excited about those distal. I don't have too much experience as well with distal nerve transfer, but in particular, targeting the anterior interosseous nerve, I have 3 cases, and I studied the literature. The cases are uniformly good. The results are outstanding. I think this is the best nerve transfer I ever made. I only have 3 cases, but all 3 cases have a very nice outcome. So I was wishing to do this transfer, and yes, I could transfer, but I have to graft, to do nerve graft from a very high level of nerve injury. So I thought at the time that distal nerve transfers would work better, but it, of course, is an option too.
It's fantastic. And we use the house tenodesis method now as well as our preferred method for the claw deformity. And I agree that the tensioning that is a little tricky. And if anything, you want to get it tighter than you think is advisable to try to hold the MP joints down in some flexion. But I think it's a great method for dealing with the claw deformity as the extrinsic flexors recover.
Okay, so Dr. Ala, we move to my second case in the matter of time. So this is a young boy, 12 years old. He suffered an accident with his bike versus a truck, and he developed a complete left brachial plexus injury. And I saw him about 3 to 4 months after the initial injury. So I'm sorry I don't have the pre-op videos, but believe me, he had a mild Klobuchar Horner sign, a complete paralysis of his left limb, a flail arm, and no latissimus dorsi or pectoralis major function as well. So I did a suprascapular exploration, and I noticed a C5, C7 avulsion in this picture. We see the upper and middle trunks, and the nerve, you can see the root ganglions, and also an inferior trunk and T1C8 avulsion, so 5 root avulsion in a 12 years old boy. So I explored the suprascapular nerve as usual, as well as this spine accessory nerve. And then I proceed with a standard spine accessory to suprascapular nerve. And then, as I learned from you and from my folks in Korea at the time I was visiting you, I perform intercostal nerve transfer. I do like this. I tunnelize the, I use a tape from the sponge to elevate the rib and a vessel loop to dissect the nerves. I use 2 nerves, and I tunnel them to the arm with the shoulder abducted 90 degrees as you teached me at that time. So we were able to perform a little bit of proximal neurolysis of the motor branch of the nerve to obtain a tension-free neuropathy. And then I use fibrin glue to augment the repair. So this is 7 years post-op. I think this is my best result of spine accessory to suprascapular. He had a very good external rotation and abduction, and he actually engaged on long jumping training, and he's part of the Brazilian national team of the Paralympics. And he was able to get during the classificatory for the Paralympics in London the 6th place. Unfortunately, he couldn't go because there was only 5 spots. I was too sad for him, but he would try again, he said. So my questions about this case is, would you have done anything different on this case? Would you consider a combined gracilis transfer in the acute setting? Probably your answer will be yes, according to your presentation. And after this result, would you consider a second gracilis for finger flexion for grasp, or even would you use this re-innervated biceps for finger flexion with like a simple tendon transfer with a tensor fascia lata tendon graft interposition as described by Oberland and also by Bertelli?
Well, the second or the last question point about using your already reinnervated biceps for an additional function, I don't think it would work. Doi has emphasized the need to have an antagonist to prevent elbow flexion if you're going to use that muscle to move the hand. So you need triceps. So you could consider doing a triceps reconstruction. In this kind of scenario, you could make it work by doing a triceps tendon transfer, like we would use the lower trapezius in this circumstance and transfer it, although you use the spinal accessory. I'm not sure you have a very good option to get grasp using that. at the time of surgery, we have some data now that's relatively new that if you compare the results of intercostal nerve crossing to biceps and intercostal nerve crossing to a free gracilis, our results are uniformly better pretty much with a gracilis flap. And just as we found in our single versus double fascicular transfer study for elbow flexion, we found that combining two nerves for biceps and two intercostal nerves for a gracilis did not result in stronger elbow flexion than a gracilis flap alone. So quite honestly, we would probably, if the goal was elbow flexion and a stable shoulder, we would most likely almost certainly use a gracilis flap. And if we're going for grasp, then we would use the spinal accessory for triceps like I showed.
Okay, thank you. Thank you very much, Dr. Bish.
Great result though, fantastic.
Okay, we can move
Thiago?
for the other case, Thiago.
Okay. First of all, I would like to thank Dr. Bishop for being here. I was a research fellow with him for 1 year at Mayo Clinic, and I was very, very well treated, and it was a very special period of my life. So it's an honor to have him here today with us. The case I'm going to present is a case of a lower trapezial muscle transfer to shoulder external rotators in a brachial plexus injury. The patient has 17 years old, had a history of 4 months of brachial plexus injury in his first evaluation. The mechanism was a motorcycle accident. In the initial physical examination, he had a active mobility of the shoulder with a deficit of abduction of M1 muscle force and a deficit of external rotation, M0. But he had a competent trapezius with M5 muscle force. The shoulder had a normal passive mobility. When examining the elbow and forearm, he had a deficit of the biceps with M1 muscle force, a normal triceps, normal wrist and hand, tinal positive sign in the supraclavicular region, and no Claude Bernard Horner present. On the MRI, the brachial plexus had a C7 avulsion, a pseudomeningocele, and a C5, C6 post-ganglionar injury. What happened is that the patient presented himself with a progressive improvement of the elbow and sensitive function while waiting for surgery. And with 1 year and 4 months, he had a recovering of the biceps with M4 muscle force, but he had a persistent deficit of shoulder external rotation and abduction associated with more than 1 year history of lesion. He had a M0 of external rotation and M2 of deltoid. And this is the physical exam prior to the surgery. You can see the recovering of the biceps, but the deficit of external rotation and the deficit of abduction of the shoulder. And because of that, we decided to do a inferior trapezius muscle transfer. In here, you can see the dissection of the trapezius together with prolongation of the fascia and the transfer to the infraspinatus muscle. We did, in this case, a direct suture to the infraspinatus muscle. In here, we can see the simulation of accessory nerve. We can see the contraction of the lower trapezius. And for the post-operative period, we immobilize the patient with this kind of orthesis for 6 weeks. This is the results we were managed to achieve. In 3 months post-operative period, we had already 10 degrees of active motion of the external rotation and 20 degrees of abduction. In 5 months, the final results was 30 degrees of external rotation. It was very satisfactory, M4, and 35 degrees of active motion of abduction, M4. This is the pictures of the results. You can see here the flexion of the elbow, the abduction of the shoulder about 30 degrees, and the external rotation. This is a video of the results. flexion, external rotation, and abduction. Considering this case, what I would like to ask Dr. Bishop is, was his and also Mayo indication for inferior trapezius muscle transfers? What are there current techniques used for this surgery? I know that there was a lot of modifications in this technique. We changed a lot. In the beginning, we were doing using anchors to insert the trapezius on the humerus, not directly on the infraspinatus. And also if you use some kind of graft. What the compared outcomes of muscle transfers and shoulder arthrodesis in brachial plexus injuries, if he had any experience with shoulder arthrodesis and when to do each one, and possible future solutions for external rotation deficits in brachial plexus injuries. That's it.
Those are your only questions, Tiago?
Yeah.
Okay. Well, clearly, I mean, that was an ideal indication for a trapezius transfer because at the time you did it, more than a year had elapsed. And so, yeah, that's the right thing to do. The interesting question is, if you had operated at 4 months, would you have done that first, or would you have used a spinal accessory or a nerve graft from C5? And that's the unknown question, I think, because in this pattern of injury with only C8 and T1 functioning, I would expect that a nerve graft from that postganglionic C5 or 6 to suprascapular nerve would probably not give you very good external rotation. And the question is, would it be better to just do the trapezius transfer? This kid, I was watching carefully as he was rotating his shoulder, and that appeared clearly to be glenohumeral rotation rather than scapulothoracic protraction. So congratulations, it's a great result. The current techniques, Bossum does these, I don't do these, but I know that he no longer uses a tendon graft. He did at the beginning. I think he prolongs some of the fascia to allow it to reach directly. And he does suture it directly into the infraspinatus tendon. Beyond that, I'm not sure about the details of how he does it. And I think shoulder fusions are still a very useful thing. Even at the beginning, it looked like his arm positioning was about neutral or maybe only slightly internally rotated. So he already could get his hand in front of his body without it moving against his chest wall. And it looked like the net gain that he had compared to preoperative was just a few degrees, maybe 20 degrees more. Nevertheless, it's a useful addition to what he had. A shoulder fusion in a case like this would probably not make him very happy. And clearly, I think that was the right answer. The people who have painful subluxation or rather marked internal rotation of the shoulder with no control may in fact do better with an arthrodesis. Bassem El Hassan is leaving Rochester in about a month. He's going to Massachusetts General Hospital. He's going to replace J.P. Warner as the head of the shoulder and elbow unit. So we're losing Bassem, and I think we'll probably be doing more fusions. Alex Shin is kind of very much in favor of it. We'll see what our patients have to say. But there's a role for both, but I think this is an ideal for transfer. Fusions probably more so in people with more internal rotation, more subluxation, and or pain. Future solutions, good question. You know, the more targeted distal reinnervation of the suprascapular nerve at the notch, I think is showing some better results than a spinal accessory transfer in the front. So that's a developing thing. Bossom will sometimes use the contralateral trapezius, or if the trapezius has been already paralyzed by a spinal accessory transfer or trauma. So there's that you could consider.
Perfect.
So I think those are the only future solutions I can think of.
Great. Perfect. Thank you very much.
Okay, Thiago. Eric.
We have another case.
So,
Okay, let's go.
A
so
lot of
again,
cases today. Not today.
Short cases now.
so hi everyone. Can you see my screen?
Yes.
As I'm Dr. Eric, nice to meet you, Dr. Bishop. I'm gonna present my case quickly because we have enough time. In summary, there's a case of 22 years old male with 1 year of total brachial plexus injury, with no recovery, with no Horner's signal, and associated of this injury, he had a clavicle fracture with occlusion of the axillary artery and ribs fractures with the need of chest drainage because of a pneumothorax on the same limb. On the physical evaluation, he had a signal sign positive on the supraclavicular region, and we performed some exams with evidence of avulsion of all roots from the plexus. This angio CT shows that there are a total occlusion of the axillary artery in this region over here. And here we can see a fail arm and some scars of the chest drainage and the permanence of the clavicle plate. So our plan, we didn't consider to perform Agdacilis free functional muscle transfer because of this occlusion, this total occlusion of the axillary artery. And we didn't consider as well to perform a nerve transfer because of he had this need of chest drainage and pneumothorax and ribs fracture. So we decided to do a supraclavicular exploration, and if we had any route available, we would perform a vascularized ulnar nerve transfer to musculus cutaneus and axillary nerve. And with no routes available, we would use the spinal accessory nerve with interposition of a sural nerve graft to biceps motor branch from musculus cutaneus nerve. So intraoperative, here we can see the C5 roots and the upper and medial trunk with a total fibrils in the whole trajectory of this nerve. More distally, we could see the axillary artery, but we could not find the lower trunk because we believed that it was dislocated inferiorly and laterally because of the avulsion. So we was trying to cut off this root, trying to find out some available fascicles at all, but we could not find any fascicles inside the C5 roots. And it was interesting because in this case, you could see a small bone fragment from the transverse process here, maybe from the spine. So we decided to perform a neurotization from the spinal accessory nerve with interposition of a long sural nerve graft for motor branch for biceps. Here the motor branch and the musculus cutaneus nerve, and the long graft, the long sural graft. This is the distal approach. And the proximal approach here with the spinal accessory nerve and the sural nerve grafts. So I have some few questions for you. I believe that you have already answered some of the questions, but would you consider to use contralateral C7 or another nerve in this case as a donor nerve? Would you have done a direct free function muscle transfer using another artery? Remember that that there was a total occlusion of the axillary artery in this case. And in cases of poor prognosis, like that case, what are you used to do? Would you consider do nothing or even do amputation of the limb? What's your purpose for that case?
Yeah, the problem here is the both the vascular injury and the elapsed time. Now you're at a year, and a nerve graft from spinal accessory to the biceps will take about 11 or 12 months to reach the muscle. So it'll be 2 years before the muscle begins to show any signs of recovery. So you've got nothing to lose by doing that because your options are limited, but I would expect that it probably won't work. I don't know that an intercostal nerve crossing would do any better, maybe slightly closer to the motor end plate, maybe give you a slightly better chance. But again, at 1 year, the results are in most cases going to be poor. So I don't think you have a lot of options beyond what you did. Amputation is a dirty word in brachial plexus surgery, but we've published a series of amputations. People who ask for it don't like the arm swinging around without control, may have pain from the weight of the arm at the shoulder. Of course, it won't help neuropathic pain, and patients need to understand that. But if the indications are right, if they just simply don't want a paralyzed arm in the way, or if the weight of the arm is causing shoulder girdle discomfort, an above elbow amputation is perfectly satisfactory thing to do. And we do it as needed. I can't think of anything else to do for this guy except wait a couple years and see what happens with your transfer.
So I don't have the result of this case because we performed the surgery last month, but I don't believe it will recover totally.
Yeah, if you get anything, it probably won't be sufficient to bend the elbow, I expect, but I hope I'm wrong.
Yeah, thank you.
Okay, Marcelo,
Okay, so
one more case.
okay.
One more case, or the last
Yeah.
one, probably. Okay.
the last
one,
four
Alan.
ones.
Hello. Hello.
Using yeah. Okay. So, Dr. Bishop, again, thank you for your participation. It's very important to us to exchange our experience. Yeah. So I'm present case is a very quick case. This is a male, 47 years old, is a partial brachial plexus injury. Time of evaluation, 16 months. It's he didn't have shoulder, elbow at all, flexion or extension, some flexion of the wrist, some flexion of the fingers, and ME4 for intrinsic muscles. Here, I'm going to present the physical examination of this patient. Partial injury, some movement, flexion, no flexion of the elbow. We did the gracilis neuroticized in ulnar nerve. 4 months results after gracilis. 10 months recovery, partial. 10 months. Instability of the shoulder that justifies procedure at this area. We use total arthrodesis of the shoulder. You can see the result, then the result with flexion, and a good result, abduction, and even external rotation. So my questions are, how important is the shoulder stabilization to augment the elbow flexion after a free transfer? Ulnar nerve and spinal accessory nerve. If you have both, which one is your first choice as a donor nerve for a free gracilis transfer? And I'd like to know about your thoughts about the suture that you do distally when you use the gracilis free muscle. How you do? You just do the suture at the distal flexor biceps tendon, or you extend it like you show in your presentation to the extensor tendons? What are you doing right now?
Great questions, Marcelo. Well, I think the Japanese have shown that the shoulder arthrodesis will improve your elbow flexion strength about 1 grade because it takes away that subluxation and positions the arm appropriately. And it looked to me like that may have been the result you had as well. Clearly, his elbow flexion was better with the fusion. So I think it is important if your nerve surgery doesn't restore a stable shoulder, a fusion is a very good idea. And that guy was really internally rotated. We see that very commonly where the forearm rests against the chest. And it's a relatively useless function to have elbow flexion with the shoulder internally rotated. Question number 2 is really interesting because we almost never see that scenario with a functioning ulnar nerve. But if they have a grade 5 flexor carpi ulnaris, I very well might consider doing the Oberlin. However, the problem with the Oberlin transfer with a gracilis flap is that the position of the nerve is generally too high, for an easy fascicular transfer. You might have to position the muscle farther down the arm, maybe fix it to the acromion to accomplish that. But then you'd still probably have a fairly long obturator nerve branch to make it a convenient transfer. So I might still go with spinal accessory nerve in that scenario. The distal suture is a really interesting question. When we first looked up my results of single and double free muscle flaps, we found that muscles transferred for more than one function, that is for wrist extension or finger extension, as well as elbow flexion, were slightly weaker at the elbow. But Alex Shin and our group has looked up our much larger series now, and we found that actually when we look back now, those muscles are stronger at the elbow, and we believe it's because the more distal connection gives it a longer moment arm at the elbow and a better mechanical advantage than a suture to the biceps tendon. So if this patient didn't have a deficit of finger or wrist extension, we're still now transferring gracilis, for example, to the brachioradialis tendon, so that instead of the biceps, to improve its moment arm and its ability to flex the elbow. In this scenario, I can't remember, the wrist extension was also absent, wasn't it, Marcelo? I would do a transfer for elbow flexion and wrist extension rather than elbow flexion and finger extension. Although you could consider a wrist fusion later as an alternative to get grasp and release. When I used Doy's method, I often had problems with the wrist not extending while the fingers did. And so I switched to emphasizing wrist extension rather than finger extension.
Okay, so next case, it's a patient is 32 years old, a young one, total brachial plexus injury, 11 months after the injury. We evaluated this patient. So M0 for all the actions of the upper extremity. So the surgical finding was a complete avulsion of the septus from C5 to T1. So we decided to do a free gracilis flap. We did a neurotization in the accessory nerve. like we show here, the proximal part, the altopectoral area, and the supraclavicular area, the flap in a regular fashion. So this is what we got after 1 year. So the questions are, in cases like this, complete avulsion injury, what's better to use? Use the spinal accessory nerve as a donor nerve. It's better to use to graft to the musculocutaneous nerve, or use this nerve, the spinal accessory, for a free muscle transfer. What's your preference? And is there time limit to decide between both? And what are the steps like in cases like this? What's your first approach? Elbow, shoulder, and wrist. Do you agree with this sequence of procedures?
Yes, I do. So in a complete avulsion injury, I mean, our results for spinal accessory or intercostals are basically equivalent. But it's nice to just use the spinal accessory. It's a much faster operation. You don't tear their chest apart. They can be out of the hospital a little bit sooner. We much prefer to use a free muscle. As I explained, our results for elbow flexion strength are superior when we target a free muscle rather than a biceps nerve transfer. So, and especially in this case, at 11 months, I would not graft to the musculocutaneous nerve. So there is a time limit for grafting. And the time limit for us is 6 or 7 months. Going beyond that, the results are going downhill, and by a year, not good at all. So I think you did the right thing. And I expect you probably use his shoulder in the next operation. And you don't have an option in a case like this for wrist and hand. It's too late. I wouldn't. I suppose you could use you could do one of our 1-stage operations with spinal accessory to triceps and intercostals to a free muscle flap. And then a later shoulder fusion. That would be the other option. But again, at 11 months, you really depend on that triceps recovery for the grasp to work.
Mm-hmm. Okay, so I promise the last one. This is a case, I compare 2 cases of neurotization of spinal accessory nerve to musculocutaneous nerve in 2 different situations. Both are complete injury, but we did in maybe a different way. The first one, 7 months, we did neurotization. In this case, then the result, we're using a short graft. The second one, for injury, we use 15 centimeters graft, doing a tunnelization of the nerve. This is 1 year result and 2 years result. This is a total injury, okay? So my questions are, spinal accessory to musculocutaneous nerve. What's your preference? To do a short graft, like the first case, or a long...
E a mãe não vai te jantar?
Tunnelization, doing the tunnelization, like the second one. And what are the limits? Because if you use the short graft, you have to dissect the musculocutaneous nerve proximally. So maybe you lose some fibers of the nerve. And the long one, you have the problem considering the size of the nerve, the graft. So what's your opinion about this?
Gee, Marcelo, you do ask difficult questions. Well, the spinal accessory nerve is, of course, considerably smaller than the musculocutaneous nerve. and a short graft right at its takeoff from the lateral cord would not match in size, and a number of the fibers will be misdirected into the lateral antebrachial cutaneous nerve. On the other hand, a longer graft allows you to to target the biceps, but it does have some potential problems. I guess I don't know the a scientific answer. Long grafts, many plexus surgeons believe, are perfectly valid, and I would probably tend to look at the motor branch, and sometimes you can combine the brachialis and biceps motor branches together. I have no experience with taking the lateral antebrachial nerve, cutting it and implanting it into muscle. That's something that some people believe can reinnervate a muscle without a direct pathway to motor end plates. And I guess that would be another consideration. If you used a short graft, maybe that would work. But personally, I would tend to use a longer graft.
Okay, thank you, Dr. Bishop. So probably James is going to say some final words. James, turn on, liga microphone.
Okay, sorry. We have now 1 hour and 20 minutes, 20 minutes later. Sorry about that. Thank you so much, Alan. It was very nice for us. Thank you for your time. And maybe we can see as soon as possible again a normal time, maybe in the near future. So thank you so much, and say the best regards for everybody in Rochester, and take care.
And it was great seeing so many friends. I would love to come to Brazil again, and I'm hoping that this pandemic will end. It seems like both Brazil and the US are seeing the brunt of the problem at the moment. So hopefully we'll all stay healthy and be free to travel again soon. But thank you for the invitation, and great to see everyone.
Thank you.
Thank you.
Thank you,
Thank
Dr.
you.
Have a good night, everybody.
Bye-bye,
Bye.
Bishop.
Bye-bye. Thank you, Dr.
Bye-bye.